So I'll be talking about the imaging of congenital heart disease, especially for CT and MRI. And echocardiography is the first line examination for the heart. There's no question about that. But nowadays, CT and MRI can be used for some assess cardiac function and morphology. So this is very short lecture, 15 minutes. So I will just introduce what we can do with the CT and MRI, not a deep detail of disease, not some findings. So in a CT, I'll show you some non-gated and gated techniques, and then introduce new generation CT scanners and concepts. And then MRI, the ventricular volume and function, RV, and flow quantification, and delayed enhancement, and extracellular volume, which MR extend its application not recently. So it will be very interesting to know what MR can do. This is the basic concept of EKG gating CT. Heart is always beating. This is taken from the MRI. So in some moment, it looks like a little bit a rest for a beating. That's the mid-diastolic phase, so-called diastasis phase. So EKG gated CT is recording EKG signals and get imaging data for certain RR interval period. Then take some slab of the images, and then next RR interval, taking the others, and so on. So as this method, we can get motion-free cardiac imaging. That's EKG-gated CT. With EKG-gated CT, we can see very details of coronary arteries and aortic root, and the other structures like valves. This case is already confusing to me because I found some very unusual space before coronary artery os, but finally it's already thickened aortic valve, and the aortic valve touched some sinotubular junction, and some aortic sinus space is separated. But anyway, as you can see, it can show some coronary arteries and os, so it can be used for the coronary artery evaluation, especially for the root, and then also can show some aneurysm and the stenosis of the Kawasaki disease. EKG-gated CT is actually gathering all the information through the RR interval, so we can get this kind of a motion imaging of the heart. This patient has a functional single ventricle and has some problem getting MRI because it has some metal clips on there, so MRI cannot work for this patient. And in this particular cases, we can use CT for functional assessment of the heart. The radiation dose is already high, so we have to be careful to concern that. The other problem is that EKG gating is if patient cannot breathhold, there is some significant stair-step artifact from the breathing. So as you can see, there is some slab-by-slab misregistration of the vessels or heart. Actually, this patient is moving a little bit, and this patient does not move, but you can see some difference of the contrast media enhancement and then small misregistration between the slabs. So in some cases, non-gating CT is enough for the diagnosis. In this case, we can see very nice TAPVR tracks and then some stenotic segment when passing the diaphragm. This is getting without ECD gating. So ECD gating is not always essential. We can get very nice images by non-gating CT, especially for the extracardiac structures and a very small child. And when patients do not stop their breathing, sometimes non-gated CT is better. Another example for that, this is a pulmonary artery sling. And this is also non-gating, but can show very nice image of the aorta and pulmonary arteries and the airway and its stenosis. The airway is one of the strong points of the CT. It can show airway very nicely. So patient has some airway problems. CT is the maybe easiest way to see that and showing this 3D structure for that. So this pulmonary artery sling and tracheal stenosis is nicely demonstrated. Demonstrated by CT images. Other one is pulmonary vein. Pulmonary vein is not so moving by the cardiac beat, so non-gated CT is enough for making diagnosis of the pulmonary vein stenosis or follow up that the pulmonary vein status. But in intracardiac structure, and especially for some beating structures, non-gated CT can show the artifact. In this case, this is aorta and this is superior vena cava. We can see some connection between the aorta and superior vena cava. It is nonsense at all. Actually, this is coming from the motion artifact. So motion artifact is sometimes very, looks like very rare, so you should be very careful to interpret the non-gated heart, or even the gated heart CT, we can see this kind of some artifact. Now we have very nice machines. One of them is a dual source CT. With dual source CT, we can do this very high pitch, fast CT scanning. So it covers 737 millimeter. It's maybe more than the adult thorax in a second. So it's faster than our breathing. We don't need breathhold for these CT scans. And then this is actually so fast, we don't need EKG gating. The heart can see as it's not moving. So this high pitch mode is quite nice tool to imaging for the child, and including the congenital heart disease. So this so-called flash mode, and it can cover the heart just in a bit. And the important thing is nowadays we can use this very low kVp. So 70 kVp is almost routine. For the adult, I use 80 or sometimes 90, not more than 100. The advantage of this low kVp is it can give us very nice contrast and also give us very, very low radiation dose. As you can see, so it's expressed by dose length profile is less than 10. Usually we can imaging the pediatric patient with less than 10 DLP. That means 0.5 millisievert around there, 0.2 or 0.5. Actually, that radiation dose is matched with 5 to 10 portable chest X-rays. So 5 chest X-ray, maybe you don't have any guilty feeling about that for the patient examination. But when you do other CT, maybe you can feel some uncomfortable about the radiation dose. Nowadays, if your hospital has this very recent equipment and you have very reasonable radiologist who can control the radiation dose, actually the radiation dose from the CT scan is not so high at all nowadays. This is some small tip when you have to do a CT scan by yourselves. The contrast media is very important. Machine is very nice and everything is just a single touching. But the contrast media protocol and preparing that is very essential for the cardiovascular imaging. And these are tips for the success imaging for the heart. Fill the line with contrast media because the patient is small. And the line, if the line is filled with cell line, the injection duration is maybe, most of them are injecting cell line instead of contrast media. So fill the line with contrast media up to the cannula. And use enough amount of cell line chaser that will give you better imaging quality and better utility of the contrast media. When we do taking CT, because the CT scan just taken in 1 second, so my recommendation is timing is to cell line is arrived SVC. This cell line is a cell line chaser after contrast media. That cell line chaser arrived in the SVC, that's the proper timing for the imaging. But we have to adjust some scan timing because I do not use a bolus tracking. I usually put my scan delay from my experience and calculate the arrival time. But patient has a right to left shunt. You have to do some earlier timing because the contrast media goes to the aorta directly from the right ventricle. If the patient has low cardiac output, maybe the arrival of the contrast media to the heart is delayed. You have to prolong that. If the patient has a BCPC or Fontan, the early arterial phase has some meaning, but it is almost impossible to pulmonary arteries and the fontan tract in early arterial phase. So we have to add some delayed phase. I usually add a 3-minute delayed, but it can be adjusted by the patient size and patient cardiac functions. This image is showing the systemic vein nicely. You can see this superior vena cava and the right brachiocephalic vein cross the retroaortic space and the prevertebral space and go to the axial vein system. And there is some small PAPVR, the left upper, this is posterior view, so left upper lobar pulmonary vein and the right upper pulmonary vein drain to the both superior vena cava or right brachiocephalic veins. This image shows the importance of the field, all the venous system as well as the artery is important to assess the patient whole cardiovascular system with the CT. As Arya already told you about in the earlier images, this is a scene from the heart. So in this patient actually has the same plane of the MRI and the CT for the cardiac function, or even mitral prolapse, and then asymmetrical septal hypertrophy, and SAM, and the LVOT. In this image, the MRI is very poor to assess that. In this case, the CT is better than C, this kind of some LVOT from the SAM. So CT can be used for some functional evaluation. But in this case, radiation dose is much more than static. Now it's 1 or 2 millisievert. Still, that is not high because our annual natural background radiation is 2 or 3 millisievert. So 1 or 2 millisievert is not high, but we should be careful for use that. So actually, the MRI is better for seeing these cardiac motions. This is MRI to see the RVOT aneurysm. The MRI is good for that, and there is no limitation for the echo window angles. We can make any arbitrary angle to this kind of CNS. And recently, the MRI used for not volumetry, but also to measure the LV myocardial mass. So LV myocardial mass is quite famous parameters, and we can use that for hypertrophy of the myocardium. But LV myocardium is so thin, very tricky to measure that. But anyway, we can measure the LV myocardium, and some report comes from that. In this report, the LV diastolic mass to volume ratio, if that is more than 0.2, that is strongly associated with a subsequent increase in LVDV. That's quite interesting. So nowadays, ML can use it for also measure the LV myocardial mass, not just the volume. And this is LV strain evaluation. This is quite experimental, but this taken from usual MR images, not tagging or some very complex imaging process. It's just to use very usual CNA images, and they track the some speckles on that and make this kind of strain images. And the echo also can do this, but LV side, maybe MR is better to showing this whole heart strain images. The MR angiography is using contrast media and seeing the vessels. It's a very nice tool to see the pulmonary arteries and the pulmonary veins. And in this purpose, CT is better. But when we do MRI, this is kind of a small additional sequence, and only use very small amount contrast media, no radiation error. So when we put patient in the MR scanner, it is better to get this MR image every times. The beauty of the MRI, it can measure the flow amount through the vessel. That's a flow quantification. In this case of pulmonary regurgitation, we routinely put the flow quantification at the main pulmonary artery and both branch pulmonary arteries. And the flow through this area can be demonstrated by velocity time curve and the flow time curve. With this flow quantification, we can see pulmonary regurgitation fraction, 62%, and the lung perfusion ratio between right to left lung, that's 85 to 15. So it's like, we don't need a lung perfusion scan to see the left to right perfusion ratio. Actually, this patient has very tight stenosis at the left pulmonary artery, and as you can see, the pulmonary vascularity is quite different, the right to the left, as Dr. Yu show you the asymmetry of pulmonary vascularity in plane. So definitely MR can also show that, but not only these morphologic changes, so MR flow quantification can show the ratio of the flow distribution between two vessels, 85 and 15 in this case. But I found very interesting phenomenon in the patient with repair TOF in many cases. This is a patient with 22 years old, a history of pulmonary atresia with VSD and PDA. And the patient underwent some reconstruction surgery for the pulmonary artery. This is a flow time profile, the main pulmonary artery. It looks almost normal and very small regurgitation, maybe can be considered as physiologic. But when we can see in both pulmonary artery sides, it's quite different from that. And the left pulmonary artery has some quite significant regurgitation. The right pulmonary artery doesn't have that. And this right pulmonary artery shows a continuous forward flow during the diastolic phase. But main pulmonary artery side, there is no regurgitation. That means right pulmonary artery flow is going to the right side in diastolic phase. So there is no morphologic change in both pulmonary arteries. There is not stenosis in the proximal segment. Actually, I think this comes from the difference of the both lungs resistancy. So left lung pulmonary resistance is much higher than the right. And in diastolic phase, many flow go back to the main pulmonary artery and go to the right side. When we carefully see the MRI angiography again, the right pulmonary artery looks quite normal, very reasonable size of proximal segment, and the branching and the peripheral pulmonary artery is quite nice. But in the left side, the central pulmonary artery is somewhat dilated and tortuous, and the segmental artery also looks very tortuous, and the diameter is not so big, and it's decreased abruptly, and the peripheral vasculature branching is quite poor. These findings are known as a pulmonary arterial hypertension. So sometimes I call this is a unilateral pulmonary arterial hypertension, but I don't know that's a proper terminology or not, because the pulmonary artery pressure in actually measuring the main pulmonary artery comes complex combination of both pulmonary artery pressures. So I don't know why, but I can find many many cases with these findings. I'm now analyzing the data. So this is a good example of what MRI can do. And actually, we can do some segmental artery analysis, and maybe we can add some pulmonary vein flow analysis. This is a quite nice image, but actually very hard to find application. This is a 4D flow demonstration of the flow, 4D bank. This is actually a 3-view angle of the usual velocity encoding scene and make this kind of a combination. The problem with this imaging is take so long time, maybe 10 to 15 minutes, and the temporal layers are still very low. But anyway, we can see this blood flow in the vessel like laser particle tracing in hemodynamic or some flow dynamic investigators. Is it image quite nice? It's quite nice. This patient actually has some regurgitation, the pulmonary artery. And delayed enhancement, MRI is quite famous to show the myocardial infarction. That is delayed enhancement, and that's originally introduced to see the infarct myocardium. But nowadays they can use that for any fibrosis and also some RV pathology. In this patient, RVOT shows very diffuse enhancement. That means diffuse fibrosis is the RVOT. And there's some report about that patient with the fibrosis in RVOT examined by MRI shows the worst prognosis and the worst parameters for that. So they conclude that this fibrosis seen in the site of the initial repair, but occasionally the extent beyond the repair site, and then delayed enhancement is associated with the increased diameter of the RVOT, decreased detection fractions of RV, and increased RVDV. And this delayed enhancement actually reflects some increase of the extracellular volume. These two pathology specimen image is showing the normal myocardium and then myocardium with hypertrophy. When myocardium has some hypertrophy, the extracellular space is filled with some fibrosis, and the extracellular volume is increased. So MRI can show this increased extracellular volume. This is known as ECV. That is quite famous concept, but introduced very early in already 1999. That's almost 20 years ago. At that time, it is introduced to explain why MRI can show the infarct tissue as delayed enhancement. Their explanation is like this. When the cells are all intact, the extracellular space is very small in the myocardium, so that is not enhanced well. But when cell is damaged, the extracellular volume of the myocardium is increased, and the contrast media feel this ECV and may show the enhancement of the myocardium when the extracellular volume is weak. That means at the time the infarct myocardium. You have to know one thing: the MR contrast agent is they are very extracellular agent. They cannot enter the cell, so they remain in the blood and remain in the extracellular space. They not enter the RBC or WBC. Maybe just to feel the plasma of the blood and the extracellular volumes. So when we see the very well enhanced structure, that means that tissue is a very large blood space or very large extracellular volume. So we can calculate the tissue extracellular space by this concept: ECF, space of the blood, and ECF, space of the myocardium. And the enhancement degree is presented as the T1 shortening time is actually represent this ECV space. And we know ECV, extracellular volume of the blood, that's 1 minus hematocrit. So with this combination, the relation equation, we can calculate the myocardial extracellular space. So extracellular volume is for for overcoming the drawback of the post-contrast T1 mapping, because in post-contrast T1 mapping, time goes down. The signal goes down by increasing the contrast media by the kidney. So we cannot compare the enhancement degree to person to person. But when we calculate the extracellular volume, it's quite stable from 5 minutes to 10 to 15 minutes after contrast media injection, and the T1 value of blood and the myocardium. And actually, we can see the decrement of the enhancement with this ECV. Actually, there's some report about using this ECV concept to patient RVOT assessment. Their myocardial extracellular volume fraction assessed by CMR is associated with type of hemodynamic load and arrhythmia in repair TOF. So it's already just the beginning. So we don't know how we can use this, and especially with the RV, checking the ECV is quite tricky. But anyway, we can use it in the LV side, and maybe assessing the patient myocardium, like transposition of great artery or CCTJ. We can measure the LV ECV and assessing the fibrosis before the surgery. Okay, this is summary. I talk about the non-gated CT and gated CT and introduce very new generation CT scanner and the concept, and about the radiation dose for that, and in MRI, ventricular volume and function, and the RV valuation, and the flow quantification, and showing the unilateral pulmonary arterial hypertension by MRI, and the delayed enhancement of the myocardium and the extracellular volume space, the concept of that. Thank you very much.